Hello everyone. In this session, we are going to study the chapter 31 abdominal external hernia. First, let's understand what an abdominal external hernia is. A lump locally formed in abdominal viscera through a congenital or acquired abdominal defect and protruding through a weak region to the surface is called an abdominal external hernia. For example, if a vessel enters clearance sac in the enterocolia, it is an abdominal internal hernia. And if can't see through vessel examination, it may be, for example, a lesser foraminal hernia, a diaphragmatic hernia. The abdominal external hernia is more common than the abdominal internal hernia. A real abdominal external hernia must be inside the sac developed from the parietal peritoneum without prolapse of viscera, while an abdominal internal hernia is not covered by the parietal peritoneum. The abdominal external hernia is one of the most common diseases in the abdominal surgery and named after the prominent anatomic position where the inguinal hernia has the highest incidence, accounting for over 19%. The femoral hernia takes the second place, accounting for about 5%. And there are also incisional hernia, umbilical hernia, and hernia of linear eyeball. Today we are going to explain the inguinal hernia. Etiology. Its occurrence is related to two factors: the decrease of abdominal wall strength and increase of intra-abdominal pressure. Decrease of abdominal wall strength. This is an etiology of anatomic structure and the basis of hernia development, including congenital type and acquired type. The congenital factors include the oblongate peritoneal processus vaginalis, the high inferior margin of oblique interior abdominis, the wide halberd back triangle, the incompetence of the umbilical ring, a defect or linear elbow on abdominal wall. Some normal anatomic phenomena such as passing the inguinal canal by the spermatic cord or round ligament, passing the inguinal canal zone by the inguinal artery and vein, may also cause the decrease of the abdominal wall strength at this position. The acquired factors include operative incision, undesirable healing of drainage incision, trauma, inflammation, and infection. Increase of intra-abdominal pressure. This is an inducing factor subject to various causes. Chronic coughing due to smoking and bronchitis of older people, chronic constipation, late trimester, or pregnancy ascites due to swelling of infant, weightlifting. Pathologic anatomy. A typical abdominal external hernia consists of a hernia ring, a hernia sac, a hernia contained, and an external tegment. Hernia hole. It is a hole where the hernia sac gets out of the intraconia, also called the hernia ring for the ring shape, in most cases, and equivalent to the weak or defect position of the abdominal wall. Various types of hernias are named after a position of the hernia hole, such as inguinal hernia, femoral hernia, umbilical hernia. A hernia sac is a sac back structure where the parietal peritoneum protrudes from the hernia hole and may consist of the sac neck, the sac body, and the sac bottom. Hernia content. It is a viscera and tissue that protrude from the intraconia and get into a sac. The common contents are those with a large range of motion. The most common one is the small intestine, followed by the augmented medulla, and other real ones include the cecum vertebrum appendix, colon sigmoidum, colon transversum, and bladder. External tegmental, it is a layer of abdominal wall tissue outside the hernia sac. These layers of tissue are often enlarged or compressed by ingress and ingress of the hernia content, leading to shrinkage and thinning. According to the pathologic changes and the clinical manifestation of hernia contents, abdominal external hernias can be classified into the following types, namely the reducible hernia and the irreducible hernia based on the reduction of hernia contents, the incarcerated hernia and the estrangulated hernia based on the obstruction in blood circulation of hernia contents. Reducible hernia. Any hernia that the hernia content can easily reduce into the intracorneal is called a reducible hernia. In general, at the early stage of an abdominal external hernia, the hernia content only protrudes when the patient stands or due to the abrupt increase of the intra-abdominal pressure. May reduce into the intraocular naturally or gently passing with a hand when the patient lies on the back. Irreducible hernia. A hernia that the hernia content can't completely reduce into the intraocular, but will not induce a serious symptoms is called an irreducible hernia. It is generally produced by the repeated herniation of hernia contents, the ointment measures in most cases, as well as the small intestine, leading to friction and damage of the surface and adhesion with the hernia sac. A hernia in which an abdominal retroposition vessel is dragged downward by the retroperitoneum during herniation and becomes part of the hernia sac is called a sliding hernia. The common vessel on the right is the sacrum. Those on the left include the colon sigmoidum and the colon descendens, and the anteposition vessel is the bladder. As adhesion is there during sliding hernias are also irreducible hernia. The hernia content of an irreducible hernia is generally free of the hemodynamic disorder or any severe clinical symptoms. Incarcerated hernia. A hernia that the hernia content can't reduce suddenly and a series of symptoms occur such as pain is called an incarcerated disorder. If the incarcerated content is the small intestine, the symptoms of acute intestinal obstruction will occur. The main pathologic feature of incarcerated hernia is the obstruction of the enteric cavity under compression, but the arterial and venous blood it supplied is not obstructed. It should be noted that if the incarcerated content is only part of the intestinal wall, but the intestinal wall by the mesentery side and its mesentery are not in the hernia sac, it would be an antimesenteric wall hernia or Richter hernia. If the incarcerated content is the macrodiverticulum, it would be a lateral hernia. Strangulated hernia, an incarcerated hernia which is not excised in time and the hernia content is subject to the blood circulatory disorder and even necrosis is called a strangulated hernia. Only one intestinal segment is generally involved in incarcerated and strangulated hernias, but sometimes the incarcerated content include two or more intestinal lobes in the shape of one. Such as a hernia is called a retrograde incarcerated hernia. Not only in the hernia sac, but also in the intraocular, incarcerated intestinal canals may be subject to necrosis. Therefore, or incarcerated intestinal nerves with pathologic changes must, during an operation, be taken out the incision for detailed examination to prevent omission. Clinically, strangulation hernia is furthered development of incarceration, and there are two consecutive stages that can't be separated. After incarceration or strangulation, a hernia would have three major symptoms: abrupt herniation and swelling of the hernia lump, accompanied by an evident pain and unable to reduce back into the intracranial. The hernia lump is solid and become hard, and the tenderness is apparent, which makes the lump not producing a sense of rush or swell like before when the patient coughs. The symptoms of the acute mechanic intestinal obstruction occur: acute paroxysmal abdominal pain, accompanied by emesis, cysts of flatus, and defections, hyperactive bowel sounds, and also abdominal distension at the later time. According to the above typical symptoms, the diagnosis would not be difficult. Section 2: Inguinal hernia. Overview of groin anatomy. Any inguinal hernia occurs when a viscera protrudes through a weak spot in the abdominal wall at the groin. It is the most common abdominal external hernia, account for 90%. According to the relationship between the hernia ring and the inferior epigastric arteries, the inguinal hernia can be classified into indirect inguinal hernia and direct inguinal hernia. Indirect hernias protrude from the inguinal canal inner ring at the outer side of inferior epigastric artery, diagonally moves inwards and forwards, passes through the inguinal canal, pierces the outer ring of the inguinal canal, and possibly enters the scrotum and account for 19%. Direct hernias directly protrude forward from the inguinal triangle at the inner side of the inferior epigastric artery, don't pass through the inner ring or enter the scrotum, and only account for 5%. The patients of inguinal hernia are mostly men. The male-female incidence rate is 51, and it is more common on the right side than the left side. The incidence rate of direct hernias is increasing among elderly patients, but indirect hernias are still more common. Anatomic layer of inguinal region. You are required to study this part by yourselves. Anatomy of inguinal canal. The inguinal canal is a latent canal in normal conditions and located above the inguinal ligaments, basically equivalent to the position among the obliques, internus, abdominis, the arcuate inferior margin of the transversus abdominis, and the inguinal ligament. An adult canal 4 to 5 cm is long. It has an inner mouth, an outer mouth, and 4 wall, superior wall, inferior wall, antisthetic, and posterior. The inner mouth is the inner ring or abdominal ring, namely the oval fissure in the transversalis vessel described above. The outer mouth is the outer ring or subcutaneous ring, and a triangular fissure below the external oblique aponeuris. The antisthetic of the canal is external oblique aponeuris and part of the obliquus internus abdominis at 1/3 the outer side. The pars posterior is the transversalis vessel and the deep peritoneum and the transverse abdominis tendon or conjoint tendon and interfallopian ligament are respectively at the inner and outer side of the pars posterior. The superior wall is aqueous transverse abdominal aponeurosis or conjoint tendon, and the inferior wall is the inguinal ligament and the lacunar ligament. The spermatic cord passes through the inguinal cord of man, and the round ligament of uterus passes that of woman. Direct hernia triangle. It is also known as the Hirschsprung triangle. The triangle is a triangular region with the inferior epigastric artery as the outer margin. The outer brim of the musculus bicuspis abdominis at the inner margin, and the inguinal ligament at the bottom margin. As the abdominal wall is not covered completely, abdominal muscle and the transversalis vessel is thinner than the surroundings, so it is a weak spot of the abdominal wall. The direct inguinal hernia protrudes forward from this spot, therefore a direct hernia triangle.